This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome back to Audible Bleeding. I'm Jacob Schwartzman. I'm here today with Dr. Peter Lawrence to discuss the Editor's Choice articles from the February 2020 edition of the Journal of Vascular Surgery. Welcome back to the podcast, Dr. Lawrence.
It's a pleasure to return, and we really enjoy partnering with you on some of your podcasts.
Just like to remind our listeners that these articles are free on the JVS website for the month of February. Our first paper is titled Migration and Sac Expansion as Modes of Midterm Therapeutic Failure After Endovascular Aneurysm Sealing, 295 Cases at a Single Center by Dr. Stenson and colleagues. This is the CME paper of the month, and for more information on this, please visit the JVS website. This is a single center analysis of 295 patients undergoing endovascular aneurysm sealing, or EVAS, from 2013 to 2018 at the St. George's Vascular Institute in London. EVAS was mostly used when patients fell outside the IFU for conventional Ivar. Early in the study, chimney EVAS was also used in some patients who were deemed unfit for fenestrated Ivar or in time-sensitive situations where an off-the-shelf solution was required. Therapeutic failure was observed in 33.2% of cases, with a secondary rupture rate of 5.4%. Modification of the IFU in 2016 did not appear to change therapeutic failure rates. Endologics has since voluntarily recalled the Nelix device. So, Dr. Lawrence, some of our listeners, like medical students or junior residents, may not be familiar with the concept of the Nelix device and this EVAS system. Can you just tell us a little bit about this technology and how it works and what it hoped to accomplish in the treatment of abdominal aortic aneurysms?
Okay, pleased to do that. I haven't personally used this device, but I am quite familiar with it. And I think that it was designed to address two issues with endovascular repair of aneurysms. That is, the patients who have very short necks or angulated necks that might not meet the IFU for some of the other devices, and also the issue of the type 2 endoleak, where the aneurysm sac continues to fill due to collaterals from either lumbars or the inferior mesenteric artery. And the development of this device includes an endo bag to fill the sac. Some people have tried to fill it in the past with coils and things, but this is actually part of the endovascular device, is an endo bag which fills the sac around what are essentially two stent grafts that are parallel to each other and can be placed right up to the renal arteries, and even with chimneys and snorkels can be used to treat very proximal aneurysm. So the Nelix device was designed to address patients that may have an aneurysm outside of the IFU, and specifically to address issues related to type 2 endoleaks.
So many of us haven't seen this in practice, and I suppose that part of the reason why is that there is this high failure rate. Are you surprised by the results of this study at all?
Well, I think anyone is surprised when a device is approved, and then later there are reports of problems. And as you, in this paper, as those of you who go and read it will find, many of the problems occur later after 2 years. So the problems with the device are those of migration, where the device slips down. In other words, the attachment to the aorta is not as secure as I believe the original developers of the device and those who used it in the initial clinical trials thought that it would remain attached right up adjacent to the renal arteries. And so there's an issue of migration. There's an issue of the sac distally at the iliac branches not being attached initially well, the sac to the grafts, and therefore there's some type 1B endoleaks. And also the fact that even when the device appeared to be in perfect position and without obvious endoleaks, that there was an increased risk of rupture at 2 years, which implies that even though they weren't seen, that there were continued problems with pressurization of the sac. Some of them were type 1 endo leaks in the proximal attachment, but some of them were actually in patients who had had a recent CT scan and it looked to be in perfect position, and yet the patients still had a ruptured aneurysm. So I think that anytime you have a device that's been approved and used, I believe this is the largest experience maybe in the world, this group, and has a lot of experience with it and finds that there are failures late, it's somewhat surprising, but it's important to document and identify so that other patients aren't subjected to use of the device.
As you mentioned, it is a little surprising when a device is initially approved and then later has to be withdrawn off the market. What do you think vascular surgeons should learn from the failure of this technology in terms of how we should interpret novel technologies that are coming down the pipeline?
Well, I think whenever you have a new device, if you're someone who feels a need to use that because it meets a clinical need, you just always need to be aware of the fact that clinical trials are intended to pick up safety and efficacy, but they aren't perfect. And when you encounter unexpected problems, it's important to report them. And it's important to make sure that you're using the device within the IFU, the instructions for use, that you're not outside of it. If you do go outside of the IFU, it should be part of a trial. In this case, the IFU was actually modified and after the initial concerns, but even with the modification of the IFU, meaning that you needed to have a longer attachment, the device with the aortic wall needed to be longer and the vessel needed to be parallel, which was not part of the initial IFU. Even with modifications, it didn't solve the problem of the late ruptures and late complications with the graft. So I think it just means that we're trying to use new devices, and vascular is one of the unique specialties where there have been a huge number of new devices developed over the last 20 years. But there still need to be awareness of the limitations of the process of getting approval. And we don't want to wait forever to get devices approved, but it means that we have to be thinking about the device and thinking about any complications that occur. And if they do occur, you need to either bring them to the attention of the FDA or bring them to the manufacturer, something so that those problems are either corrected or in this case, the device was recalled.
This may be a difficult question to answer, but the concept seems like a relatively good concept. Do you think that there are any things that can be done to improve this technology and reattempt its use in the future? Or should we stick with conventional Ivar moving forward?
Well, I think we should stick with the conventional Ivar, but there are a subgroup of patients who are too high a risk for open surgery and have aneurysms that need to be treated and cannot be treated with the currently available devices. So I hope that Endologics and the Nelix device undergo modifications in either how the sac is developed, how it is attached to it, and how their proximal attachment on the aorta can be developed so that it becomes a better device. I'd also point out that although I haven't personally done this, I've been told that when there is device failure with the Nelix device, that it's not easy to remove. In other words, it's difficult to remove. So when there is a failure, patients sometimes have to undergo an open operation. So we need to make sure if the new device, the new Nelix with modifications is developed, that it is used in patients who are often high risk for open surgery. So it's important that it be durable and that it lasts for a number of years, longer than the life expectancy of these patients.
Our second paper is titled Carotid Endarterectomy for Asymptomatic Carotid Stenosis is Safe in Octogenarians by Glausman and colleagues. The authors queried the ACS-NSQIP CEA targeted database from 2012 to 2017 to identify all patients undergoing elective CEA for asymptomatic carotid stenosis and stratified those patients into greater than or equal to 80 years old versus less than 80 years old. Outcomes focused on 30-day mortality and stroke rates, octogenarians were found to have a slightly higher mortality overall. However, this was still relatively low in terms of absolute mortality rate at 1.2 versus 0.5%. The rates of stroke were similar between the two groups at 1 versus 1.2%, and stroke death rates were also similar at 2.0 versus 1.6%, with no statistical differences in the latter two figures. There were no statistical differences in the rates of adverse cardiovascular events, pulmonary or renal dysfunction, or wound complications. So, Dr. Lawrence, this is the first study to really analyze octogenarians specifically undergoing CEA to attempt to establish the safety of this procedure in an older population. What findings did you find most interesting in this paper?
Well, first of all, it seemed as though the surgeons who were doing carotid endarterectomies and participated in NSQIP were selecting patients very carefully and were assessing them well because they got such good results. I guess I was surprised at how close the results of those over 80 were to those under 80. The other thing that I thought was particularly interesting is one of the things which isn't collected in the NSQIP data, and realize that NSQIP is limited to 30 days, so it's not looking at 1 year or 2 year outcomes, which can be looked at in VQI, but not in NSQIP. One of the things that happened was that patients who were over 80 had a higher return to the operating room for bleeding. And although they don't collect the data in NSQIP, at least that's my understanding, but the question is, did they reverse heparin at the same rate? Because as you probably may know, in the VQI study, reversal of heparin after carotid endarterectomy was associated with a reduction in return to the operating room and no increase in stroke rate. So I'd be very interested in whether the surgeons who participated in NSQIP reversed the heparin. And if not, that's a very important message, which is even in 80-year-olds, you need to reverse the heparin after your carotid endarterectomy. So the two surprising things were how good the results were, but the fact that return to the OR is something that you want to avoid in an 80-year-old. And it may be that the simple solution is to reverse heparin.
So obviously, anybody reading this will note that the mortality rate was significantly higher in octogenarians. Should we be concerned about this, or is this expected given the age distribution of the subjects?
I think it's somewhat expected. Whenever you operate on older people over 80 and do an elective operation, you need to make sure that their life expectancy is great enough to benefit from the procedure. And so, although this is a mortality and operative mortality, the difference is very low. So I'm not really concerned about it, but I do think that whenever you get into doing elective operations on asymptomatic patients that are seniors and elderly, that you have to make sure that you're doing this procedure and it's going to extend the life expectancy of the average patient, since they don't have that many more years to live as opposed to somebody who's 50 or 60 years old.
The octogenarians in the study had lower incidence of smoking, obesity, and diabetes than the younger cohort. Do you think this had some influence on the study results, and should this influence how patients are selected for CEA within each age group?
I think it definitely had an impact on the outcome. Had a prospective randomized trial been on asymptomatic octogenarians with an equal distribution of risk factors, the mortality and the stroke rate might have been even higher. So this is, to me, an indication that the surgeons who did these procedures used very good judgment and were careful in limiting the procedures to those who had fewer risk factors, which I think is very appropriate. But it also tells you that if you see an asymptomatic patient over age 80 who has a carotid stenosis, that you need to assess those risk factors. And the other thing I would point out is that a significant number of patients in this NSQIP study had what we would consider a moderate stenosis of less than 80%. I believe that there was a category of 50 to 79. And, a third or 40% of patients fit in there. Those are the ones where you really have to question whether they needed the procedure. For greater than 80% stenosis, I think it's much more compelling, the argument, but I think you have to really be careful about assessing risk factors in those who are over 80 but have a 50 to 79% stenosis.
Yes, and as you already mentioned, it's very important to keep in mind the life expectancy of the patient when you're deciding to proceed to the operating room or not. Our next paper is titled Nationwide Trends in Drug-Coated Balloon and Drug-Eluting Stent Utilization in the Femoral Popliteal Arteries by Mohapatra and colleagues. This is a VQI-based analysis of patients undergoing peripheral vascular interventions involving the SFA and popliteal arteries from 2010 to 2017, with the goal of identifying trends in the use of drug-coated technology. Cases were divided into pre- and post groups with a cutoff of September 2016, when the specific device identity was first recorded in the VQI. 91,000 arteries in approximately 55,000 patients were treated during this time period. There was an overall decrease in stenting rates from 45% in the pre-era to 34% in the post-era. Within the post-era, SFAs and popliteal arteries had similar rates of DCB use. However, they were more likely to receive a stent than the popliteal arteries. In general, drug-coated balloons and stents were used to treat longer lesions than their non-drug eluting counterparts. Similarly, stents were more likely to be used for task D lesions and, in general, longer lesions and more complicated lesions. Finally, there was significant variability in DCB and DES use within the 18 de-identified geographic regions. For instance, DCB use ranged from just over 10% in one region to just under 40% in another region. So, Dr. Lawrence, there's a lot of information in this paper. Which of the findings do you think are most interesting?
Well, I think that what I was somewhat surprised at, and I think it's a reflection of the fact that this is, even though it's a huge study with VQI, that it's a selected group of patients. And in fact, that many outpatient labs were not represented. But I was surprised at the low percentage of patients that had atherectomy. And I believe this is probably because many who have a practice that's office-based may not participate in VQI. The other thing is that with the concerns about whether the drug-coated balloon with the anti-proliferative drugs are associated with an increased mortality, which is something that has been raised in several large studies, and this is something the FDA is looking at as we speak, that the number of drug-coated balloons and stents used has to be questioned in terms of whether or not it treats the lesion in the leg, but may increase mortality. So far, I don't think there's any clear-cut answer to that, but when you have a significant increase in drug-coated balloons and stents, and you're concerned about long-term mortality in those patients, I think this is an important paper that shows this trend, and I think it's going to have to be addressed as far as long-term mortality in this group of patients.
Why do you think there may be regional variation in DCB and DES use? Do you think there are socioeconomic factors in play, or might this just reflect different training paradigms throughout the country? What are your thoughts on this?
Well, I think it has to do with who participates in the VQI in different parts of the country. Differences in specialty, that in some parts of the United States, there are more vascular surgeons who are participating in VQI. In other parts, there are more interventional cardiologists or interventional radiologists. And each of them may have a different approach to using the drug-coated balloons and stents. So I don't think there may be some variation based on the complexity of the disease. And in certain parts of the country, for example, the Southeast may have more patients with higher risk factors and therefore more complex lesions. But my suspicion is it's more about the biases of the physicians who participate in VQI and do the procedures.
One last question, sort of broadly, where do you see these trends going in the future?
I think so much will depend on what the conclusion is as to whether the drug coating of balloons and stents increases long-term mortality. And if it does, there will be a movement toward fewer. It doesn't mean that they shouldn't be used, because obviously if you have critical limb-threatening ischemia and you have a device, drug-coated, which can reduce amputation, increase activity and independence, that may offset the long-term risk of mortality. But it means, as we've looked at our own group, and I think many people have thought it, that for claudicators, there probably will be fewer drug-coated balloons and stents until this issue of long-term mortality is resolved. For patients with critical limb-threatening ischemia, I think that it's far more important to deal with their ischemia than to worry about the long-term mortality, which is maybe different, but may not be dramatically different. In other words, it's important to save the limb. But in claudicators who can benefit with an exercise program and may not need a procedure, I think you've got to really question whether you want to use a drug-coated balloon or stent at the present time.
Our last paper is titled The Vascular Quality Initiative 30-Day Stroke and Death Risk Score Calculator After Transfemoral Carotid Artery Stenting by Dr. Dakour Aridi and colleagues. This is a VQI-based analysis of patients undergoing transfemoral carotid stenting, excluding lesions due to trauma or dissection and lesions treated without embolic protection devices. Logistic regression was used to identify risk factors for 30-day stroke and death, which were then converted into integers for creation of a risk score. 10,753 total patients were identified. Significant risk factors included age, non-white race, diabetes, coronary artery disease, CHF, symptomatic status, and contralateral occlusion, while protective factors included preoperative statin and dual antiplatelet therapy use. A scoring system was then developed, and 5 risk categories were created for simplification purposes. For reference, the stroke and death rate of a Category 1 patient was approximately 1.24%, while that of a Category 5 patient was 13.4%. So, Dr. Lawrence, this is obviously a new tool to add to our armamentarium in terms of counseling patients. How should surgeons be using this risk score? And is the data strong enough to warrant avoiding transfemoral CAS in some patients?
Well, I think, first of all, it's important to consider risk, and risk scores are a helpful way to do that in the pre-procedure time with discussing with patients. And there has been concern since the CREST trial, particularly with carotid stenting, that in octogenarians, patients over age 80, that there was a significant increase in stroke and mortality. So essentially what this is doing is it's putting that information in context and saying what risk factors contribute to that increased risk of stroke and death. And is there a subgroup of patients who may have a low enough risk that they could have transfemoral carotid stenting? It also will allow comparisons between the TCAR, transcarotid, and transfemoral carotid stenting, because as you know, with transcarotid, there's reversal of flow and you don't have to put the catheter through the aortic arch to get it into the carotid artery. And most people believe that the age 80 is sort of a marker for patients who have more complex tortuosity of their aortas and have more plaque in their aortic arch, and that putting that catheter through there is what causes the increased risk of stroke. So now that there's an alternative TCAR, it means that the transfemoral approach is going to be looked at very carefully as far as who should and should not have it. Particularly, is there a calculator that could give you advice about who should have the transfemoral, who should have the transcarotid, who should have medical therapy, and who should have an open procedure. So I think that having this large database and looking at each important risk factor, which has been looked at in previous studies, has given us very good information and advice about a range from just over 1% to over 13% for stroke and death risk in these 5 different categories. So I think it's going to be very useful for clinicians in advising patients and also deciding if they have all 3 options or all 4 options available at their own institution, which one should be used in each patient.
As the authors mentioned, in a study like this, external validity is always a concern. What may be some of the next steps in terms of establishing external validity in order to get this scoring system more widely used?
Well, I think that what will probably happen is the same authors will now look at different data, and they might move from, sometimes I know that they're not all the same authors, but many of them are. They may go from VQI to NSQIP and look at the NSQIP data. In other words, it needs to be validated in order to use it as a risk calculator. As you may know, the American College of Surgeons in NSQIP has a calculator for general surgery and for surgical patients. And I think risk calculators are increasingly being used. They're usually pretty simple because they have risk factors that everybody considers, but rather than looking at them individually, is this patient diabetic? Are they over age 80? It adds them together, and you can check off all the important risks and then say to a patient and to yourself, this patient has, based on a very large data set, has a 5% risk of stroke, or has a 10%, or has a 15%. And I think most clinicians who do the procedure, if they knew that there was a 15% risk of stroke as opposed to 1%, they might either recommend no treatment or another alternative. So I think it's going to be really valuable, but it does need the validation by some other database, and it may be NSQIP. And I suspect that these same authors will be sending a paper into the Journal of Vascular Surgery about the validation of the VQI developed risk calculator.
Thank you for that. One last question. Are there any other variables that are not in the VQI, such as the type of aortic arch or calcium load or presence of ulcerations within the plaque, that you think should be added to this model and may modify the decision-making process?
Well, they should be, but risk calculators have to be simple. And the age 80 is, some people feel, is a proxy for the things that you just mentioned. The tortuosity, the aortic arch, the amount of calcium in the arch, the presence of ulceration or ulcerative plaques are more common in 80-year-olds. So the risk calculators need to be simple, and they need to be information that's available to most clinicians. So I suspect that these things will be looked at, but only if they're regularly available will they be used in a risk calculator. So I'm not sure that each of them are realistic. In other words, how do you assess aortic arch or calcium load? And does everybody get a CT angiogram before they do a transfemoral? So it may be that some of these are important to look at, but they may not be in a risk calculator just because they're not simple and they're not obtained in most patients.
Dr. Lawrence, thank you again for joining us. This concludes our February edition of the JVS Editor's Choice. We look forward to talking to you again next month.
Great, Jacob, and it's a pleasure to work with you on this project.